So I'd like to welcome you all here this evening. My name's Hannah Travers. I'm the Vice President of the RULU Club. The RULU Club is the National Trainees Network for vascular trainees, and we represent everybody from training number trainees to medical students, foundation doctors and core trainees. And this venture is an educational programme between us and the Vascular Society to educate our juniors. We hope to cover the basics of vascular surgery and give you top tips and tricks for thriving on a vascular firm, especially as you're about to rotate jobs. Please ask any questions at any time via the question and answer box, and we would like to have your feedback as well on how it goes. So I'll introduce the other panel members now. We've got Rachael Forsythe, who is an ST7 up in Scotland. We've got Shaneel Patel, who's the current president of the RULU Club, and he's an ST5 in the Northwest. And we have Leanna Erete, who is an ST4 in London. Now, these sessions are going to be hosted by the different deaneries across the network of vascular trainees. So I'll hand you over to Leanna. All right.
Right, welcome everybody. So this evening I'm going to be talking about how to take a history from vascular patients. So learning objectives, how to take a vascular history, and as with every other area in medicine, it follows the same format. So introduction, presenting complaint, history of presenting complaint, past medical history, family history, drug history, social history, ideas, concerns and expectations, and if you're doing a comprehensive history, a systems review. So in terms of introduction, it's very important to introduce yourself, say your name, who you are. It's always worth having a look at the hashtag Hello My Name Is on Twitter that was set up by a doctor a few years ago, because this is an area that doctors can sometimes be very poor at. It just helps set the scene and helps build a rapport with the person that you're speaking to, your patient. Also confirm your patient's details, so ask for name and confirm date of birth. And then next you want to get permission from them to continue talking about what they've come in to speak about. So in terms of presenting complaint, you want to find out from your patient why they have chosen to seek medical attention. And it's important to document this in the patient's own words when you write this in the notes. You don't want to be interpreting it yourself. You want to write down what they've said verbatim. So moving on, you now want to drill down further into the history of the presenting complaint and find out some further details about it. So this is by no means a comprehensive list, but this is just some ideas that you can ask about. So when did their symptoms start? How long have their symptoms been going on for? How severe their symptoms are they affecting their daily life? Are their symptoms constant, or are they intermittent? Is there any pattern throughout the day? Are there any factors that make things better or worse, the precipitating or relieving factors? Are there any associations? For instance, if somebody's noticed that they've got some ulceration on their foot, are they also experiencing temperatures, which might be an indication of infection? And have they had any similar episodes to this in the past? In clinic, I also ask at the end of this, is there anything else that you want to mention that I haven't also asked about? So moving on, specifically talking about pain, I'm sure we all learned a similar mnemonic at medical school, but I'll just run through it again. So Socrates regarding pain, so talking about site, onset, the character of the pain. So is it a dull ache? Is it a sharp pain? Radiation, is it going anywhere else? Associated symptoms, as I mentioned previously. Timing, are there any exacerbating or relieving factors? So anything that's making it better or worse? And severity. So moving on, I've tried to section this into vascular pathologies that you might see commonly in clinic, in A&E, or on the ward. So in terms of aortic pathologies, it's common for us to see in clinic people with abdominal aortic aneurysms. There's a picture for you. Often these are asymptomatic and they're picked up incidentally. So they can either be picked up because somebody's had, say, a CT abdo-pelvis for for some gastrointestinal problem, or they might have had a CT-KUB for query renal stone. However, some patients do notice that they've got a lump in their abdomen, and sometimes they may say that they can feel it beating in time with their heart, so a pulsatile mass. And then sometimes these patients can have pain, which can be on a spectrum from mild to severe. If the pain is severe, then you need to have concerns about whether this is a rupture or not. So you need to investigate that a bit further. So if you were speaking to them, say in resus in A&E, you might be wanting to ask about dizziness. If they've got someone with them, you might want to ask if they had a loss of consciousness, heart beating faster, if they felt sweaty, things like that. So moving on, something else that we see commonly in vascular patients is peripheral arterial disease. Again, a picture for you. This shows an acute ischemic limb on the right-hand side. So with acute onset, it can be sudden, very painful indeed, and I hope you'd have learnt by now about the 6 Ps of acute ischemic limbs. So pain, this is something you can ask about and explore that with Socrates. You wouldn't really ask about whether somebody's got a pulse or not. That's something that would lend itself more to examination, which Shaneel will be talking about later. You can ask your patient whether they've noticed any difference in colour from one side to the other. Have they noticed any numbness or tingling? Have they had any trouble moving their foot or any problems walking when before they were okay? And have they noticed that there's a temperature difference? So is it poikilothermic, which means has it taken on the temperature of the surroundings? We also see patients that can have chronic arterial disease. So these questions, you're investigating more about whether they have intermittent claudication. So this is a situation where the pain worsens on exertion, but is relieved by rest. It's also important to ask how far they're able to walk, as this gives you an indication of the severity of the claudication. If you're not able to get a specific distance, such as 100 meters, 200 meters, and so on, you can ask how many lampposts can you walk before you get out of breath, and so on. It's also very important to ask about rest pain and tissue loss. So rest pain is when you've got ischemic type pain, even if you're not exerting yourself. Tissue loss is either ulceration or gangrene, necrosis of the tissue, as these are both signifiers of critical limb-threatening ischemia. And there's a picture of a foot that has some ulceration and tissue loss. We also increasingly see patients that have acute on chronic disease. So it's important not only to find out their claudication distance, but to find out how long they've been experiencing intermittent claudication for. Sorry, I should have said about the critical limb-threatening ischemia. That's essentially the end stage of peripheral arterial disease. So I won't go into these in detail, but it's just worth knowing, especially for those of you doing exams, there are classification systems for peripheral arterial disease. Popular one at the moment is the Wi-Fi wound ischemia and foot infection. There's also a couple of older ones, Fontaine and Rutherford. So moving on to venous disease, we frequently see patients with varicose veins in clinic. So the kind of questions that you want to be asking to elicit history about these. So there's a picture for you. Is your patient experiencing any heaviness in their legs? Do they have any aching sensations? Have they had any ankle swelling, any itching, any bleeding, which can sometimes be from scratching due to the itching? There can sometimes be skin discoloration. It's important with this to think about the skin color of your patients. Caucasian patients might have different discoloration features compared to patients with darker skin. Ask about ulceration. Shaneel will go through in more detail about the differences between arterial and venous ulcers. Saphenous varix, which can present as a lump in the groin, And it's also important to ask about whether the patient has had previous DVT, any previous surgery on the affected side, or any trauma on the affected side, as all of these can raise the risk of developing varicose veins. So moving on, you then want to ask your patients about their past medical history. So again, this is by no means a comprehensive list, but I've chosen things that are often relevant to vascular patients. So diabetes, as I feel we all know, your risk of developing vascular pathologies is significantly raised if you have diabetes. Hypertension, so high blood pressure, can raise the risk of developing AAA. Heart disease, and by this I mean AF, raises your risk of developing clots. MIs or angina, so any ischemic heart disease, suggests that you are a vascular path. Respiratory disease, so if somebody has COPD, it might suggest that they've got fairly significant smoking history. It's also important to think about their respiratory function, because if they do need intervention, will they need a general anaesthetic? It's important to factor in their respiratory function. Patients with renal disease, it can be common to develop vascular pathologies as well. Important to ask about strokes and TIAs, considering carotid disease. Important to ask about whether they have raised cholesterol in terms of thinking about atherosclerosis. Clotting disorders, and whether they've had any previous surgery or procedures. And by procedures, I mean IR procedures such as angioplasties. And I think it's important to ask both of those things separately, because somebody that's had a wire down their leg might not consider that to have been surgery. So moving on, family history. Try and keep it to first degree relatives, so explain that you would like to know if there's any conditions that run in the family that have affected their parents, their siblings, or their children. You don't really need to know about great aunt Mavis. This is particularly relevant for men with a direct male relative with a history of AAA. The risk of them developing a AAA themselves is approximately 4 to 6 times higher than without. And varicose veins, there is some correlation if you have a female relative and you're female yourself, that you're more at risk of developing them. So next you want to move on to drug history. So you want to ask what medications they take, including the dose, how often they take them, and also do they actually take them. It's all very well being prescribed warfarin once a day, but if you only took it 2 weeks ago, then that obviously has an implication. Specifically, it's always worth asking about anticoagulation, whether that's warfarin, as I mentioned, or whether it's some of the newer ones, such as rivaroxaban, apixaban, and so on. Important to find out if these patients are taking antiplatelets, and if they're not, consider starting, and the same with the statin. Ask about over-the-counter medications, and ask about allergies, not just what the allergies are, but what the reaction is to the medication or the substance that they have an allergic reaction to. So next, moving on to social history. Number one question, ask about smoking. Some people might actually ask about this in past medical history. Wherever you ask it, if they do smoke, and very commonly vascular patients often do, it's one of the biggest risk factors for developing vascular pathology, offer them smoking cessation support. Important to ask about occupation, and if they're retired, ask what they used to do. Ask about alcohol intake. Ask about recreational drug use if you feel that this is something important to ask. And if you are going to ask this, make sure that you ask, do they inject any drugs? As this can have implications in terms of pseudoaneurysms and so on. Ask your patients about their living arrangements. And by that, I mean, do they live in a house, a flat, a bungalow, their stairs? Are they able to get up and down the stairs? Do they live with anybody? Do they care for anybody? Do they have carers coming in themselves? Excuse me. And in terms of why they've come to see you, find out in more detail, how does this impact on their activities of daily living? You know, if somebody's got a chronic limb ischemia, is that affecting their job as a lorry driver, for instance? Somebody may be a carer for their partner, and pain is not allowing them to maintain their caring responsibilities. So next, you want to explore a bit further about ideas, concerns, and expectations. to ask your patient what they think might be wrong. They often have an idea themselves. They've obviously felt unwell enough that they want to seek medical attention, so they already may have some thoughts about what might be wrong, in terms of they know other people that have had similar, or they've read something on the internet or whatever. Once you found that out, explore what they're worried about. For instance, somebody that has got a painful leg might be worried that their leg is going to be amputated. And then discuss what they're expecting now in clinic, on the ward, or in A&E, and in the future. So it might be that they're expecting a scan to be booked now, and then in the future they might have an operation which would hopefully help their symptoms. So moving on, just briefly, if you have the time, and if you're doing a very comprehensive history, it's always worth asking about other systems, as obviously there's overlap between these all. And finally, no presentation about history taking would be complete without this quote from William Osler saying, "Listen to your patient, he is telling you the diagnosis." Thanks very much.
Okay, so thank you very much, Leanna. I thought that was very thorough. And the next step in the patient assessment is, of course, vascular examination. So I really start by saying that there's no substitute for getting hands-on with examination during the learning process, even from the early stage. And so obviously in this era of Zoom talks, we'll do our best to try and get across all the clinical examination findings to you. But do grab a vascular registrar or a consultant and nab 15 minutes of their time. They're usually very willing to take you through this examination. And the structure of a vascular exam really follows the principles of the other systems that you'll learn when you're preparing for exams, but we do split them into 4 anatomical regions. Upper limbs first, then examine the carotids, then move to the abdomen, and then focus on the lower limbs, which usually in an exam setting is the focus for the station. And then within those, you stick to your classical divisions of inspection and auscultation, if appropriate, in a few areas, which I'll show you. Palpation, which is more than just feeling for pulses, and percussion doesn't really have a role in the vascular examination. This is often considered a bit of a soft start with the examination, but I can't stress the importance of it enough, really. Introducing yourself properly, confirming the patient's details, making sure that they're happy for you to examine them, washing your hands, and then asking for a chaperone, both to make the patient feel comfortable and to protect yourself, is of crucial importance. And in medical schools in particular, and even at MRCS, you'd be expected to do these things, otherwise it can be a red flag. In terms of the vascular examination, you want to expose the patient so that you can access all of their limbs, their feet and their abdomen. So really it does mean getting them down to their underwear, and you can use a sheet or a blanket to obviously preserve their modesty as you examine each anatomical region in turn. But I start them up with 45 degrees in bed. That is the most comfortable position for a patient to be examined in. It's really only when you get to the abdomen and the top of the limbs in the groins that I place the patient flat, and then I bring them up to 45 degrees again straight away. And of course, it's crucial to ask if they're in any pain before you start manipulating any parts of their body. So we start by standing at the end of the bed and performing a general inspection, really. And in vascular patients in particular, there is a wealth of information that you can gather through this step. So they often have obvious deformities, whether it's parts of their limbs that have been amputated, very obvious scarring or skin changes. You may see prostheses and mobility aids that range from simple walking sticks right up a spectrum to a wheelchair. And their bedside table can also give you some information about their kind of nutritional status and some medication perhaps lying around, such as inhalers. And I think it's useful to gauge how well your patient is from the end of the bed. They may be obviously in pain, they might be a bit drowsy. Someone who's comfortable and smiling at you sets a very different tone for what you might be finding on examination to someone who is in pain. So really just try and take a gross overview in at the time. And then we start off with our anatomical regions, the first of which, as I mentioned, is the upper limb. And of course, we start with inspection, and the vascular exam is focused on inspection, if I'm honest with you. you get so much information just from closely looking at things. Here in the top left, you see tobacco staining of the index and middle finger. By the time they've got to this stage, it suggests they've got quite a significant smoking history. It's in these two fingers always because they're the fingers that people tend to hold a cigarette in. This is an arteriovenous fistula. I'll just explain for the more junior of our medical student audience who might not be familiar with this. This is an access point for patients to have dialysis. So blood is taken out of this surgically created connection between an artery and a vein, and it's also returned to the patient from the dialysis machine. This is quite a prominent aneurysmal fistula, so it may not be that obvious, but because a significant proportion of our patients do have chronic kidney disease, it wouldn't be unusual to see a fistula in a vascular examination. Here we see gangrene or necrosis, and that refers to obviously dead black tissue, and this is due to ischemic peripheral vascular disease of the upper limb. You can tell that the blood supply is not ideal in this arm. There are skin changes, the shininess, the thin skin, the flaking. These all come together with that necrosis to suggest poor inflow into the hand. And vascular disease, although much more common in the lower limb than the upper limb, can present like this, especially where gangrene like this is dry. I'll explain that in a bit more detail later, but this is a stable situation, so they may well bring patients like this to your exam. This is a kind of purpley, dusky discoloration to the tips of the fingers. It's actually fairly non-specific. A patient with very severe respiratory disease might present with this. It's called cyanosis. It suggests that you have a low oxygen saturation level to your blood. But at the same time, having an actual obstruction to blood flow in the hand, particularly acutely with acute ischemia, can also present with duskiness. So it's just something to bear in mind. You want to compare this to a nice, healthy pink color of the hand. And I've never seen this before, but this is xanthomata. So these are cholesterol deposits in the hand. You may have heard the same ones being described in the eyelids as part of the cardiac examination, and they're called xanthelasma. And really, you have to have cholesterol levels really high to see this sort of deposits, and they're usually in the setting of familial hypercholesterolemia. So already a lot of information you can glean just from having a look at the hand. And then we move on to palpation. And before we get into pulses, you must check for temperature, use the dorsum aspects of your own hands to feel the skin, feel both sides at the same time so you can look for asymmetry, and also conduct a capillary refill time assessment. So capillary refill time refers to you occluding the microvascular supply to the soft tissues of a distal finger. You occlude for 5 seconds and you release. And if you have good inflow into your hand, you would expect that tissue to return to its baseline color within 2 seconds. It is, however, a non-specific test. It can be an issue with the heart or the peripheral vascular system that gives you a positive result, but it is a nice screening tool. And then pulses. So in the upper limb, we start with the radial arteries. Here you see someone using their index and middle fingers to feel the radial arteries of both wrists at the same time, which is the conventional way to do it. You find the radial pulse lateral to your tendon sheath bundle at the wrist, as you can see here. You're assessing to feel if you can actually feel a pulse. And also whether there is a difference between the two sides in terms of the strength of the pulse, but also whether they're delayed one respective to the other in terms of time. And that can suggest peripheral vascular disease in the arteries of the upper limb, but also possibly aortic dissections or even coarctations, which are quite rare. These vessels are useful for you to assess the rate. It's important to know if a patient's bradycardic. This can suggest heart block and other cardiac issues, or the fact that they're on medication. They may even be tachycardic, which is of crucial importance when assessing the acutely unwell patient. You will also be able to assess whether it's a regular rhythm or not. And that's really important because, in particular, AF is implicated as a direct cause of thromboembolic disease from the heart. So that's something to definitely check for. And then you move up the arm in sequence, really. We start off with the brachial artery. Here again, you see 2 fingers medial to the biceps tendon, and you'll be able to feel the brachial artery if present. And you can do both sides of the body at the same time. The axillary artery is easily felt by applying pressure over the upper aspect of the humerus, just distal to the armpit. It's quite difficult to do these at the same time, so I'd probably do them one after another. And then the subclavian artery, as you can see from this kind of anatomical diagram, you have the medial and the middle thirds of the clavicle. And if you were to feel superior to that, in the supraclavicular groove, we call it, you will feel a pulse. Don't feel too lateral, because by that time the artery has dived down into the arm. And as these are larger vessels, you'll be able to feel and assess for the volume of the pulse and the character as well, which you probably can't do at a smaller vessel like the radial. So then we move on to the carotids. And again, we follow our structure. So it's a new anatomical segment. I would start by inspecting again. And here you can see a scar. It runs from the ear and it runs anteriorly down the neck to the sternum, which is in the midline. And that's a classical incision to access the carotid arteries. And the most common operation is a carotid endarterectomy. That's a clearance of the intimal layer of the vessel that has enlarged and caused narrowing, and it's an operation done to reduce stroke. And you may actually even see lumps. It's quite rare, but tortuous vessels that kind of deviate towards the skin surface, or carotid tumours, or even carotid aneurysms may be seen. And then you want to auscultate and palpate the carotid artery. You find it in between the larynx and the sternocleidomastoid mastoid muscle that you can see the sternal head for here. Some light pressure and you'll feel a carotid. Now, you should start by auscultating. And you may hear a bruit. A bruit is simply defined as turbulent blood flow, and it's the equivalent of a murmur, but murmur is usually used to describe heart valve issues specifically. And if you feel a carotid bruit, hear a carotid bruit, I should say, it can suggest the presence of a narrowing or a stenosis, as we say, within the artery. If you're in an exam, I don't think it would be unreasonable to actually say you'd be reluctant to palpate in that situation. In theory, you could dislodge atherosclerotic plaque that could cause a neurological event. So I think it'd be sensible to mention that. And we never palpate the carotids at the same time. You can cause dizziness and even syncope, so the patient could pass out through reduced perfusion to the brain. So one at a time for sure with the carotids. That's it really for carotids, and then we can move on to the abdomen. You won't see this very often, but I just thought it's a lovely photo that was shared in the New England Journal of Medicine last year, and it's of a giant aortic aneurysm, just showing that you can pick things up with inspection alone. And really, from a vascular specific point of view, we're only really looking for incisions. Of course, there is a wealth of information you can get from looking at an abdomen with a general surgical examination, stomas and scars and what have you. But from a vascular point of view, it's really just the incisions. The laparotomy incision is running down the middle here. Above the belly button, we use that to access the aorta. If your operation involves the common iliac arteries, that incision can go round the belly button and into the lower half of the tummy too. And I'd also bear in mind that there are some surgeons across the country who fix abdominal aortic aneurysms with a horizontal laparotomy incision above the level of the belly button. And if you ever see an oblique incision in either the right or the left iliac fossa, this is called a Rutherford-Morrison incision, and it's used for access to the external iliac artery. And the external iliac artery has many uses. It's commonly, especially with a big incision like this, it would be used for a kidney transplant. That's the vessel in which the donor kidney is attached to in the recipient. But in vascular surgery specifically, we can use the external iliac artery to control bleeding that's occurring further down the leg. So just bear that in mind. And then palpation. Palpation of the aorta is two-handed. You can see here that we use all the fingers pretty much to press down and inwards around the aorta. The reason for that is, as explained, so first of all, you want to assess if there's a pulse. That doesn't really tell you too much in isolation. In a skinny person, you will feel a palpable aorta. In a heavily comorbid patient, you may actually have an aortic occlusion. So if they're thin and you can't even feel the aorta, then that should be at the back of your mind. But really, the reason for a two-handed technique is to assess if the aorta is what we describe as expansile. So what that means is that the transmitted pulse to your fingers is not vertically up, it's slightly oblique and diagonal anteriorly, and that's pathognomonic of an aneurysm. And then in terms of auscultation, we have these points on this diagram to listen to, again, for bruits. And like I explained, it's turbulent blood flow. That may be the case within aneurysms or within narrowed arteries. You can't tell from auscultation, but you can tell something's up. So you would listen for the aorta in the midline above the belly button, the renal arteries just at the costal margins in the upper quadrants on each side, and the iliac arteries at the superior aspect of the right and left lower quadrant. And then onto lower limbs, which will often be the focus. You may even be asked just to examine the lower limbs. And there are, of course, obvious things to find in the lower limb, and I will go through them as well. But don't ignore the subtle signs, because most patients have all of these, and this should be mentioned in your examination. So these are signs of poor arterial inflow to a leg. You can see here that the nails are brittle, slightly discolored. The skin around the toes is flaky, it's dry. This patient has absolutely no hair below the level of the knee, which can be a sign of arterial disease. And then there is this kind of dark reddish hue to their toes. We call this a hyperemia, and this becomes more pronounced as the feet are kind of dangled over the bed, and I'll explain a test that we do for that later. So definitely look closely for these signs and mention them in a vascular exam. And then we have more obvious findings. So if we start here on the left, you see the subtle signs that I'd already described to you earlier with the discoloration and the flaky skin and the unhealthy nails. But here there is also ulceration. So ulcers are breaks in skin. That's all they're described as. You can see one here. You can see small ones at the tip and even on the dorsal aspect of the third and fourth toes. They can be small and they can be in between the toes. So do separate them slowly. And you can get ulcers on the plantar aspect and under the heels. Now, a patient may not have their feet dangling over the edge for you to see the heels in an exam. So definitely make the effort to lift the feet up slightly to have a good look under the heels and on the plantar aspects. I will describe ulcers in due course, but I just wanted to say that ulcers on the plantar aspect at pressure points when you're standing are almost pathognomonic of someone with peripheral neuropathy having a neuroischemic ulcer, so a combination of peripheral neuropathy and arterial disease. So just bear in mind that the most common presentation for this is in diabetic patients. You may see amputations, of course. They can be at a variety of levels, from toes all the way up to above the knee. Here you can see an ulcer that's on the amputated wound, and you're not sure if that's acute or chronic from this without a story, but it's something to describe. And of course we have black tissue again, like I described in the hand. Necrosis and gangrene are synonymous terms. This is dry. What that means is there's no discharge and there's no concomitant infection alongside the gangrene. And wet necrosis suggests the opposite, that there may be pus coming out of the necrotic tissue. You often have cellulitis that's been marked here with a pen spreading up from that area of ulceration. And wet necrosis really needs to be admitted in a hospital for antibiotics, whereas dry necrosis is a relatively stable state that may very well be brought to an examination. And so now that I've touched on ulcers, we should really go over how you were to describe an ulcer, because during an exam, you really want to describe the ulcer in detail, either as you find it or in your summary at the end. And you want to say where the ulcer is, just describe it in terms of basic anatomy. You want to give an estimation of its size. You want to describe the base of the ulcer, so the actual tissue that you can see within it. If you get this kind of red, layer to it, it's actually a good sign. It shows that there are little blood vessels. We call that granulation tissue, and it suggests that the wound might heal. Whereas if it was completely white, you'd worry that it was an ischemic base, and that ulcer would never heal or even get bigger. The base may actually be necrotic and black, like you saw of the toe. There may be a green layer to it, and that can suggest a Pseudomonas infection specifically. And there may be slough, and slough is really the breakdown of tissue during the development of an ulcer. It's a combination really of granulation tissue, but also dead material. And as a general rule, we like to remove slough to speed up the healing process. So do describe any kind of fleshy or stringy, it's often yellow material inside the ulcer. Now, the edge is crucial because that gives you an indication of what might have caused the ulcer to break out. And it's this diagram in the middle that I'll take you through. So if you see a sloping edge, so what that means is a gradual transition from the skin surface to the base of the ulcer, then that's common with venous ulcers. So these essentially is describing a shallow ulcer. And this is a shallow ulcer here at the malleolus of the foot, and that's classic for a venous ulcer. Whereas here you see an ischemic ulcer, an arterial ulcer. It's deep, and we describe that as being punched out. It's got a very well-defined edge, whereas these ulcers, it almost merges into the skin, and you can't really tell where ulcer begins and where healthy skin starts in these cases, but you can here. Undermined edges are quite difficult to assess for. They're very rare. You won't see them in a vascular setting. But something to note when looking for ulcers, if you actually ever see anything growing out of an ulcer, so here you can see that the actual epidermis is rolled out. That's pathognomonic of a basal cell carcinoma or a rodent ulcer. Or if you see the dermis layers, so the pink layers actually growing out of the ulcer, you would worry that that's a malignant transformation. So something to always bear in mind. You could comment on whether it's discharging or dry. That's often a clue for infection, especially if the discharge is discolored. And you'd want to comment on the surrounding skin. So as an example, you could describe this ulcer in your exam by saying that there is an ulcer present on the medial aspect of the first metatarso-phalangeal joint. It is approximately 3 by 3 centimeters in diameter. There is a healthy granulating base, although the skin edge is punched out and pale, suggesting that this could be an arterial ulcer. There are no signs of active inflammation or infection with discharge or cellulitis. So it only takes 20 seconds. And if you've learnt this list, you'd be able to put together 2 or 3 sentences quite easily. We're still on inspection. This was the point I was making, that really you get so much information just from looking at a limb, and you want to look at scars. And the beauty of vascular surgery with scars is that we operate on blood vessels. So if you see an old scar, it is indicative of the vessel underneath that, directly underneath it, that we've operated on. So if we start at the common femoral artery, you see this red line, that's showing where the common femoral artery lies. It's at the mid-inguinal point. So that is the halfway point between number 1, which is the anterior superior iliac spine, which is the bony prominence laterally of the pelvis, and the pubic symphysis at number 2, which is in the midline. So it's an imaginary line. There is no structure running between the two. So you have to kind of delineate point 1 and 2 for yourself and find the halfway point. I'd just like to share a little tip. It's never in the groin crease. You can feel a pulse in the groin crease, but you're not sure at that point if it's the profunda or the superficial femoral artery that may have originated there. So stick to your anatomy. It's often 2 or 3 centimeters above the groin crease, and feel for the common femoral artery there. But at this point, remember, I'm just showing this as part of inspection. For your exams, particularly the written ones, bear in mind the difference between what I've just described and the midpoint of the inguinal ligament, which is similar linguistically, but very different anatomically. And it spans the same point at number 1, the acis on the pelvis, but it goes to the pubic tubercle rather than the pubic symphysis. And that is not an imaginary line, that's actually a ligament that runs between the two. And the halfway point is where my cursor would be now. It's more lateral and more inferior to the common femoral artery, and that is the deep inguinal ring. So that would be here. So just really try and be aware of the difference. But common femoral artery incisions will cross the mid-inguinal point, and they're often, most commonly vertical, but they can be horizontal if you're doing a limited operation where you just need to access a small segment of the common femoral artery. But the crucial aspect is to know your anatomy. So if you're at the mid-inguinal point and there is an incision there, you can be fairly confident that someone has accessed the common femoral artery. And in the modern vascular day practice, you may have the most tiny incisions ever at the common femoral artery mid-inguinal points. Through these skin punctures, they're often nothing more than skin punctures, we can repair aneurysms and perform angioplasty and stenting of arteries. So do have a close look to see if you can see old tiny scars at the mid-inguinal point. And then we carry on down the leg. And the next arterial area we operate on with a direct incision overlying it is most commonly the popliteal artery. Now ignore the rest of the incisions. I just want you to focus on this, this incision here, which is on the medial aspect of the leg above the knee, and this one which is on the medial aspect of the leg below the knee. Now through these incisions you can get to the popliteal arteries, the above knee popliteal and the below knee popliteal. The actual popliteal artery behind the knee is most commonly accessed here with this lazy S configuration incision. So you can really look for 3 incisions to suggest popliteal access. Now the tricky thing is that in an operation to do a bypass of the lower leg, you may combine your incisions to access more than one structure. So all of these incisions put together overlie the great saphenous vein, which is used as a conduit for bypass surgery. Now, it is completely plausible for the surgeon in this case to have harvested great saphenous vein, but also access the popliteal artery through these incisions. So just bear that in mind, that if you have medial aspect incisions, it may be just great saphenous vein. It's probably the case here if it's just below the knee. Cardiac surgeons prefer to do that. But if it's above the knee, just bear in mind you can get to the popliteal artery through that too. And this is a nice diagram. This is the medial aspect of someone's leg on the left. This is the lateral aspect of someone's leg on the right. And I just wanted to use this diagram because I couldn't find any photos, unfortunately, but the posterior tibial artery can also be accessed on the medial aspect of the leg lower down. You can also get to the perineal artery by digging a bit further in through the same incision. On the lateral aspect, you can get an anterior tibial artery incision as so. And you can also access the perineal artery through a lateral incision. And this dotted line shows the distal aspect of the fibula that has to be excised to get to it if you're, if you're approaching it from a lateral perspective. So then we get on to palpation. So we've got a wealth of information already just from looking. We'll get even more from palpation. And I wouldn't jump straight to feeling pulses. Again, like in the upper limb, assess for temperature changes with the dorsal aspects of both your hands, starting from the toes, running up all the way to groins, actually. I'd do that. Capillary refill time, again, is a nice gross test of perfusion to the distal part of the limb. And do a brief sensory examination. This is not a neuro exam. Everything in vascular that disrupts sensation, whether it's peripheral neuropathy with diabetes or acute limb ischemia, tends to happen from distal first up to proximal, and we call that a glove and stocking distribution. So you simply want to test sensation with light touch of your fingers across the toes and moving higher and higher until you find a level. And then we can start on pulses. So again, you want to use your fingers at the same time to feel the mid-inguinal points, and you can again compare the 2 sides. There's a nice video on this from this reference in the New England Journal of Medicine. So if you want to note that down, it's the source of these photos that I'm referencing, and they have a nice video for you to watch as well. It's a well-known publication. This is how you feel for the popliteal pulse. You rest your thumbs on the tuberosity of the proximal tibia, and you have your fingers in the popliteal fossa behind the knee, and the vessels are slightly lateral to the midline. In big patients, the popliteal arteries can be relatively small actually and quite difficult to feel. So I don't put much by feeling an absent popliteal pulse, and I would definitely get some imaging though if I could not feel it. This is how you feel the dorsalis pedis. The dorsalis pedis is the continuation of the anterior tibial artery that runs down the anterior aspect of your lower leg. We'll be going through the arterial tree in more detail in a later session, but you feel with 2 fingers lateral to the extensor hallucis longus tendon that's quite obvious to see in everyone if you get them to flex their big toe. So you want to feel just adjacent to that. And the posterior tibial artery, which is the second major vessel that enters the foot, can be felt by pressing posterior to the medial malleolus of the ankle. And then really you want to do this maneuver that's called Berger's test, and it gives you an idea of severe vascular disease. So positive Berger's test is not for mild vascular disease. It's often a sign that accompanies the other signs of critical limb ischemia, and it's in 2 steps. And you really complete your examination with this. So the first step is to elevate the leg to 45 degrees as shown. And if the foot goes pale while it's being held in the air, that is abnormal. So someone with a normal arterial tree, their foot could be pointing at 90 degrees, completely up to the ceiling, and the foot should not go pale. So that's the first abnormality. You may see this subtle sign when the foot is elevated. I didn't mention it earlier on because you need to elevate the leg to really see it, but it's called venous guttering. So against gravity, blood is obviously not flowing into the leg in someone with vascular disease, and as a result the venous system fails to fill, and you're left with these gutters where veins have collapsed down in the subcutaneous tissues, and that should never happen with someone who's elevating their legs and has a normal arterial inflow. But then there's a second part to it that has to be positive to be overall Berger's test positive, and that is to essentially place this leg in a dependent position. So that means hang it down. And it can be done in this way, shown in this diagram. I prefer just to actually sit the patient on the edge of the bed because it's more comfortable for them, really. And you'll see this appearance that we describe as a sunset foot. And it's really a red or purple or pinky intense discoloration of the foot, and we call that a reactive hyperemia. So as the foot's become ischemic, when you've elevated it into the air, you have metabolic waste products that lead to massive vasodilation of the arterioles and the venules in the foot. And so when you place their foot back down and gravity does draw blood back into the foot slowly, you have this massive dilated bed that fills up, and the foot becomes as so. And so step 1 and step 2, if they're both positive, it's Berger's positive, and they probably have severe inflow disease. I just wanted to say that in a textbook, when you're preparing for exams, it will say, try and calculate the Berger's angle. Now that takes time because you've got to essentially repeat the test with the foot held at different angles off the bed. And they say that a Berger's angle less than 20 degrees is a really severe ischemia. In an exam, I probably would just do it to 45 degrees as the default starting position for the test, and mention to the examiner that you would try and calculate the angle at which you get a positive result, and they'd usually be happy for you to move on. And then once you've finished your examination, it's usually convention to say which bedside investigations you'd like to conduct. So just be aware of the ankle brachial pressure index. You want to measure the systolic blood pressure at the arm. Instead of using your steth, though, you use a handheld Doppler ultrasound probe to listen for the signals, but the way of measuring the systolic blood pressure is as you would otherwise. And you then also want to calculate the systolic blood pressure at the dorsalis pedis, which I showed you earlier, and the posterior tibial arteries, not at the same time, one after another. It's just that this diagram is showing you where you'd place the probes. And you want to calculate a ratio. So in theory, in a completely patent arterial tree, the systolic pressure at the arm should be identical to the systolic pressure at your foot. And so the ratio would be 1, and it would signify a normal arterial tree. But if, of course, you have narrowings or occlusions in the arterial tree taking blood supply to your leg, obviously the systolic blood pressure would be lower in the foot than it would at the arm. So as your ratio gets progressively lower, we kind of use these to signal how severe your arterial disease is. And these are the values that are kind of used with convention. So that's it really for examination. There's a lot of material there. I suppose the take-home messages really are to stick to each anatomical segment in turn and perform almost like a mini examination of each section, and to start with inspection, because inspection really is key with the vascular examination. Thank you.
Thank you, Shaneel. That was a really great presentation. We have got a couple of questions come through. So the first one is, would you ask specifically for history of connective tissue disorders, e.g. Marfan's or EDS in history taking? Leanna, do you want to answer that?
Yeah, sure. I don't think I would ask if it was, for instance, a 75-year-old heavy smoker with what I thought was chronic limb ischemia, but if somebody came in and they were very tall, slim, had features that were marfanoid, then I would consider asking. So I'd tailor it to the patient. I don't think it's something that I would ask every single patient. What do the rest of you think?
I think I'd agree with you there. I think if it was a particularly young patient, or with symptoms that might suggest it, or an unusual presentation that wasn't our standard vascular presentation, then I would ask it, but I wouldn't ask it routinely to all my patients that I see.
Agreed.
Yeah, agreed.
And then we've got another question, Shaneel, I don't know if you want to answer this. Does O2 saturation for limbs, is it helpful in assessment of limb perfusion?
Okay, so yeah, it's a good question. You've got to remember that O2 saturation is reflective of how well your lungs are working. So all O2 saturation tells you is how much oxygen is bound to hemoglobin. In someone with a normal arterial tree, you can detect that in the distal extremity, and that will give you an idea of how well the lungs are working. It doesn't give you an idea of any vascular anatomical obstructions to flow. We rely on blood pressure to help us do that. And so really you want to focus in on pressure measurements rather than oxygen saturation. Would you agree with that?
Yeah, I'd agree with that. Any other questions from anybody? I think we've heard a lot of information this evening, but they've been really comprehensive. I think my top tip and trick for anybody starting on a vascular firm or seeing patients in A&E, or even if you're on the acute medical unit as rotations start, is that if you see a dressing, take it down and have a look what's underneath, because we've all been there and had surprises, and nobody's going to criticize you if the nurses say they're busy. Ignore them. Like, you do need to take the dressings down and have a look at what's underneath, and you can always get the dressing and redress it yourself as a temporary measure, but definitely always look at what's underneath.
Yeah, I would second that, and also I'd go as far to say as please make sure you examine the patients. So it's been said to me not that long ago by a junior doctor when I said, so what pulses did the patient have? And they said, well, I haven't examined them because you're going to do that. And I don't think that's acceptable, because when you move on from your, for example, first job as a junior doctor in the vascular firm and go to a medical job, your medical colleagues will ask you about vascular problems, because lots of people think vascular surgery is some sort of mystical specialty and they don't understand. So as an F1 who might have done 4 months of vascular surgery, you may then be called upon by your more senior medical colleagues to go and examine a foot and refer it to the vascular registrar. So please do examine patients and don't just wait for your senior registrar or whoever to do that for you.
I think it's a great way to learn as well. You don't know what's abnormal unless you've examined normal people. So you won't know that a pulse is missing unless if you felt what a normal pulse feels like, or if an aneurysmal pulse behind the knee, when you feel it, you know it. So I would definitely encourage as much examination as you can.
Yeah.
Anyone else got any other top tips or tricks?
Certainly when I was a vascular F2, and this is something I now do with foundation doctors on my team, is to get them to use the Doppler on one another. before they use it on patient, just so they can get familiar with it and hopefully not pick up any pathology in each other, but just get used to handling it, what it sounds like, how much gel you need to use, and so on. So I think that's a good tip.
And another thing actually I would say is, and this is a sort of fairly basic rule, but you'd be surprised how many people break the rule, is don't make stuff up. If you can't feel a pulse, just say so, even if you know the patient's got a normal arterial tree, because actually if you stood 10 vascular consultants up together and got them to feel one patient's pulses, they wouldn't all agree. You know, palpating pulses, doing clinical examination is very important, but people aren't always 100% correct. It's not 100% specific or sensitive. So just tell the truth, and you might be wrong, but that's much better than making up someone's got 2 radial pulses when actually they've got an occluded subclavian artery on one side and they don't have radial pulse on that side. So.
Yeah, that's another very good point. So if there aren't any other questions, I think we'll draw the session to a close. It's been just under an hour. Thank you very much all for attending. The next session is on the 13th of August, and that's going to be hosted by George Dovell, who's one of our Southwest trainees. And so there'll be trainees from the region of the Southwest who will be presenting, and they are going to be talking about vascular anatomy, the clinical application and imaging in vascular surgery. So we will send out some feedback forms. Everybody who's attended will get a certificate if you would like one, providing you fill out the feedback. They'll be sent round via an email in the next couple of days, and we'll send out the link as well to register for the next webinar. So I hope it's been useful.